Hi everyone, welcome to the Med Talk by Dr. Yoko. Today let's review a really interesting article together. It's all about vaginal birth and how evidence-based management makes delivery safer and smoother. If you think reading an English article is hard, don't worry. I show you that it's actually fun and easy. We will go step by step together. So grab your coffee and let's dive in. This article is a narrative review from Obstetrics and Gynecology Open 2024. It summarizes key evidence on how we can optimize outcome for both birthing people and babies. From pushing techniques, pain management to cord clamping and third stage care. I love how it turns complex data into clear, practical recommendations. Here is today's agenda. We will go through each topic together, step by step, so you can enjoy reviewing the article and understand the key critical takeaway easily. Statistics. For this slide, I quickly searched for the most recent statistics from Japan so that I can compare them with the numbers reported in these US articles. In 2021, there were about 2.5 million vaginal births in the US and over 800,000 in Japan. That is 60-80% of all US deliveries and nearly 79% in Japan. Wow! Vaginal birth is the main pathway for most mothers. Let's see what makes it safer and more effective. Stage of labor. Since we are talking about the stages of the labor, I included the definitions here for reference. Understanding each stage helps us recognize normal progress and identify when intervention may be needed. The first stage begins with the onset of the regular uterine contractions that cause progressive cervical dilation and effacement. It ends when the cervix is fully dilated to 10 centimeters. This stage is divided into two phases, the latent phase and the active phase. In the latent phase, contractions are mild and irregular and cervical change occurs slowly. In the active phase, contraction becomes stronger and more regular, and the cervix dilates rapidly. Second stage. The second stage starts when the cervix is fully dilated, 10 centimeters, and ends with the delivery of the baby. This is the stage of active pushing and fetal descent. Third stage. The third stage begins after the complete delivery of the baby and continues until the placenta be delivered. This stage focuses on monitoring uterine tones and preventing postpartum hemorrhage. Immediate versus delayed pushing. Should a patient start pushing right away or wait a little bit? Studies show immediate pushing leads to a shorter second stage and even lower infection and bleeding rate, with no negative effect on the baby. That is great news. So sometimes pushing right away might actually be better. Effects of Neuraxial analgesia. Epidural or spinal anesthesia may slightly lengthen labor, but not in a clinical significant way. What matters most is the patient's preference. So moms, pain relief is your choice and it's totally valid. Laceration prevention. Here's some great news. Simple methods like perineal massage, warm compresses, and even a sideline position during labor can reduce tearing. It's amazing how small things can make such a difference. Episiotomy. Routine episiotomy? Nope, not anymore. While it can reduce certain severe tears, it often increases pain and stress urinary incontinence later. So now we perform it selectively only when necessary. Delayed cord clamping. Waiting 30 to 60 seconds before clamping the cord gives babies more blood, iron, and oxygen. If a newborn needs immediate help, cord milking can be a good alternative, except in very preterm cases. Tiny actions, big impact. Delivery of the placenta. Active management using uterotonics, cord tractions, and massage helps with placental delivery. But interestingly, study shows no major difference in anemia or blood loss compared to natural expulsion. So balance and gentle care are key. Pitocin administration in the third stage. Oxytocin is ideally given when the anterior shoulder is delivered. It's a great way to prevent postpartum hemorrhage. Timing matters, and this small step saves lives. However, in clinical practice, I usually wait until the placenta is delivered because sometimes oxytocin can cause strong uterine contractions that make placental delivery more difficult. These decisions often depend on the clinician's preference and judgment of what's best for the patient at the specific moment. It's also helpful to know that evidence supports giving oxytocin as early as the delivery of the anterior shoulder, particularly in patients with a history of postpartum hemorrhage. In such cases, I may choose to start Pitocin earlier than usual. Summary of recommendations. So here is the takeaway. Immediate pushing is safe and efficient. Pain control should match patient preference. Warm compresses and gentle methods prevent tears. Delay cold clamping when possible. And give oxytocin at the right moment. Reading articles like this helps us connect science to real-life practice and makes medicine more enjoyable to learn. Thank you so much for watching. If you enjoyed learning with me, don't forget to like, comment, and subscribe to MedTalk by Dr. Yoko on YouTube. Let's keep reading, learning, and growing together, one article at a time.